Okay. Okay, I've hit that button. For everybody who's on here tonight, welcome. I learned today that this is the most snow we've had for opening, I think, since 1995. That plus the cold weather means that Deer Valley broke it's the first time ever that I'm aware of that they're opening early. So our town is rocking and rolling, which makes the fact that we get to have our last preseason lecture tonight even more exciting. We are thrilled to have Mary Vecchi, who is one of our providers, who is at the Round Valley Clinic, which—
One moment.
I don't know what that was. My cell phone. Let me turn that off. We're really excited to have— oh, geez. That's my cell phone. Sorry about that. We're really thrilled to have Mary Vecchi, who's one of our providers from what's called the Park City, what do we call that clinic there?
The Round Valley Clinic?
Round Valley Clinic, yeah. And it's the place where if any of you are sick or need a physical or need immunizations and call me and say, who do I go to? You're looking at her. So welcome, Mary, if you want to say a few words about yourself. If not, we'll let you get right into it. And as in the past, if you have questions, just put them in chat and we'll get to them later, or just shout out. And meanwhile, except for that, please turn off your microphone so that if you start snoring, Mary, I won't hear it. Or if your dog comes in and starts barking, I won't be afraid I'm about to be bitten. So with that, Mary, take it away.
All right. Well, unfortunately, I can't put myself on mute, so I apologize if any of my kids comes in screaming, but we'll deal with that if it happens. Nice to be with all of you again this year. I'm looking forward to a great season. I hope the snowfall continues. If so, it could be one of the best in a long time. So here's hoping. I am going to go ahead and share my screen. And yes, absolutely, it's easier if you keep yourselves on mute as long as you're not speaking, but also please feel free to speak up. You are not going to offend me. The more informal this is, the more you share your questions at the time they're pertinent, and and feel free to share any personal experiences or any questions you have about something that's happened out there on the Hill. I will do my best to answer and or open the floor to any of the other more experienced patrollers to share their knowledge about how we can handle these situations so that we can keep people as safe and healthy as possible when they're on the mountain and and being taken care of off the mountain. So let me see. I think if I push this button, I should be able to share my screen and then pull up my PowerPoint. Let's see.
We see you loud and clear.
All right. Is that showing up for you?
Well, what we see are a bunch of cute kids. Are those your kids?
Uh-oh. No, that doesn't sound right. Let me see.
Hold on 1 second.
If I go in here, it says I'm screen sharing now.
Yeah, well, now we see it says Intermountain Healthcare and a bunch of your
okay, yeah. So I think it must have, I probably didn't
there you go.
have the ball or whatever they say. So
yep, I think we got it now. There we go.
Great. And let me just move this so I can do this. There we go. Looking good?
Looking wonderful. I'm glad I'm not that person.
Yes, agreed. There are a couple of shots of some skiers like this, and yeah, we'll get a little bit to the end about, you guys see a lot of stuff. So head trauma and TBI is a pretty big deal. The topic of this lecture was head trauma, but I'm going to focus primarily on TBI, which stands for traumatic brain injury, because that's really, I would say, really kind of the biggest deal of what you're dealing with when there's a head trauma. We'll touch a little bit very briefly on bleeding related to lacerations on the head, skull fractures, and facial fractures, but mostly just to say that when any of those things have happened, you need to be thinking about the fact that in addition to managing whatever bleeding there is, this is really about trauma to the brain. Because anytime there's any kind of a significant injury to any part of the skull, you got to be thinking about the health of the brain. So the objectives of the lecture: so understand a little basic anatomy and pathophysiology, and then evaluation of the individual who has had a head injury, stabilization procedures. So, this is mostly how to take care of them and pack and ship and kind of what you need to do while we're figuring out what the appropriate patient disposition is. So I saw this through sort of your organization's website, and I think, when I saw this, I thought to myself, this is I was looking for statistics about how much of what you see is injury to the head. And actually the majority of the injuries that you deal with skiers are head injuries. 38.5% of all injuries, more than any other part of the body, if we break it down that way. So this is really important that you understand how best to care for people when they've had a head injury. Because in other words, if you think that you are going to patrol and you're not going to see a head injury, you're just wrong. It's something that you're definitely going to see and definitely going to take care of. And it's just really, really important to understand what we need to do for these patients and why, so that hopefully we avoid any further injury to the brain. So a couple of FYIs about TBI. So this is the most common cause of death and disability among children. And now this is head injuries of all kinds, but certainly something that we see a lot in kids on the mountain, in addition to elsewhere. Also interesting to know, males are twice as likely to have a traumatic brain injury as females. And it represents 72% of all catastrophic injuries in males in skiing. 80% of traumatic brain injuries are mild, but even mild traumatic brain injuries, and certainly the more moderate and severe brain injuries, can result in long-term or lifelong deficits. So this is really a big deal, and it causes a lot of not just death, but also just disability in people in the long run. The other thing that is just an important thing to remember from the get-go, if you are dealing with somebody who has had a traumatic brain injury, who has had a head trauma, you should be assuming spinal injury until it's otherwise ruled out. Because anytime there's a serious head injury, the likelihood that there's been concomitant damage to the spine is just super high. And then in specifics to skiing and patrolling, so there were 54 reported catastrophic incidents during the 2021-2022 season in the United States, happening at resorts, patrolled resorts, and the vast majority of those were man versus tree. So injuries of one kind and another, but the vast majority of them were TBI and from an individual hitting a tree. The other thing to know about traumatic brain injury is that these patients can sometimes be the most challenging. Often the injury that they've sustained can cause them to be combative, which can make caring for them difficult. They can also sometimes have a difficult airway because of jaw clenching, because of vomiting. So that can present challenges as far as taking care of them while you're getting them to definitive care. The other thing that can be really challenging about traumatic brain injury, and we'll get into this a little bit more, is they can appear normal when you get to them and you're evaluating them, which is why it's important to know that about TBI, to suspect a TBI, and be continually reevaluating and educating the patient about what the risks are if they don't get evaluated in a more definitive care setting. Okay, so the goals when you're taking care of a patient who has a TBI is that is to keep further harm from occurring to even one additional brain cell. So we're going to get into this a little bit, but basically you can't change anything about what's already been harmed, but the way that you take care of a patient can really change any further harm from happening as a result of the injury. And then you really want to just set up and establish as soon as possible optimal conditions for healing and recovery of the brain. And the way that we do this is by rapidly identifying the injury and transporting to appropriate medical care. So This is going to be a very, very brief and cursory overview of brain anatomy, because the truth is that you don't need to understand that much about the anatomy and physiology to take good care of these people. But just as a reminder, we have cerebrum, cerebellum, and brainstem, and then coming down from the brainstem is where the spinal cord is. So as you can see, if you are talking about a crush or a crash injury of any kind to the head, we are very, very closely related to the spinal cord and the brainstem, which is, as you probably know, or maybe don't, very importantly involved in things like breathing. So it's just, you have to protect the spine, and you have to make sure that you're thinking, brain and spine are going to be related, and especially these, C3, C4, C5 keeps the diaphragm alive. You want to make sure that you're thinking about protecting that neck if there's been a head injury. And then this is actually just looking more at the layers. And while, again, this doesn't necessarily affect the way that you're going to take care of a patient in the field, it is sort of interesting to know about the different layers when we are looking later at how these different bleeds that can happen within the cranium, why they happen the way they do. And that basically has to do with how the different layers or meninges that protect the brain, how they're set up, and it creates potential spaces, and how the blood spreads within those spaces is really dependent on which part of the layer has bleeding. And what kind of a bleed a person has is also actually dependent on things like age. So these things do become important, particularly when we're taking care of them in a more definitive care setting like a hospital. But it's just sort of interesting to understand, and knowing about these layers will help you to better understand why bleeds occur the way they do. So pathophysiology of brain bleeding. So the brain has very high oxygen requirements, actually really the highest of anywhere in the body. And so the brain is going to act using its power over the rest of the body to increase oxygen anytime there's an injury. So if the oxygen drops, the blood vessels in the brain will dilate. And that is in an effort to increase the blood flow to the brain to try to improve healing and sort of mental status, right? So no matter what happens in the body, if oxygen is dropping, those blood vessels in the brain are going to dilate. Which, if we're thinking about the setting of a brain injury where we have swelling within a space that is limited, like inside the cranium and an intracranial bleed, then this is going to cause vasodilation, or increase in the blood vessels is going to cause an increase in volume, which then is going to increase, increase the damage to those cells. So why it's important for you to understand this pathophysiology really comes down to, let's think about where we are. We are at altitude, which we'll probably talk about this a little next week in the oxygen station. But basically, the oxygen level is already lower when you're in altitude at baseline. And anytime that there is any decrease for any reason, particularly in a trauma, when we're thinking about the brain, use that oxygen. Anytime that the oxygen is lower than 90%, there's going to be vasodilation in the brain, and you are going to increase the risk of further damage to the brain. So you really need to use that oxygen. When you're thinking that there could be a traumatic brain injury, it's just oxygen, oxygen, oxygen. You want to think about getting more oxygen to the brain to reduce any further injury that's going to occur from the brain trying to get its own oxygen levels up. So when we think about TBI, we can break it into two categories. There's the primary injury, which actually that's happened. There's nothing that you can do about the injury that has occurred to the brain from the initial trauma. So contusion, hemorrhage, damage to the nerves and blood vessels. Once this has happened, there's nothing that you're doing in the field that can change that primary injury. And actually, there's not a whole lot that we do in a hospital actually to fix that. There's very, very little recovery of damage that happens from primary injury. What we can control is secondary injury, and that's the injury that occurs as a result of further tissue injury. And this tissue, after there is a traumatic brain injury, is very, very susceptible to that further damage. It is just it basically needs perfect conditions in order to avoid suffering further damage. The biggest thing that can cause this is hypoxia. So again, oxygen, oxygen, oxygen. The other thing to be thinking about that can cause problems is hypotension, which causes hypoperfusion, which kind of does the same thing as not enough oxygen. The other thing, which, again, there's nothing that you can do about this in the field, but the other thing that we think about is mass effect. So, but this is really the reason why it's so important to get someone with a brain injury into a hospital setting as soon as possible and to get that CT scan. Because if there is a bleed in there, and particularly if it's an expanding bleed that's causing midline shift of the brain, we got to drain it. We got to get them into neurosurgery, and we got to get that blood out, because that's really the way that we can prevent further damage to the cells in the brain. The other thing to think about, and this is, again, maybe not so much something you're thinking about at the time of the injury, but second impact after you have had a recent traumatic brain injury is much more likely to cause damage to those cells that are still recovering. So this is why if you come in to see me after you've had even a mild concussion, I'm going to say, you might want to be a little bit careful for the next few weeks. You really want to allow your brain time to recover, because it's a big deal if you get a second concussion in a short period of time. So, you fall off your bike, or and you smack your head and you're, a little dazed, but you don't lose consciousness. You're pretty much okay. This is like, you want to think about, maybe you want to, lay off the at least extreme downhill biking for a couple of weeks, because if you have another impact, those cells are just a lot less likely to recover. And then the brain remains susceptible for hours to weeks afterward. So this is why we just have to keep taking care of these people, and why they come to follow up in a primary care setting, even if it's determined that they're doing pretty well and they don't have any major needs for neurosurgical intervention. We want to make sure that the patients understand that this is a time to be very cautious and careful with your brain. So we'll start with at the sort of lower end of brain injury, which is cerebral concussion. Concussion is a broad term. And I mean, really what it just means is a knock to the head. But we usually use this term when you have had any symptomatic mild TBI that doesn't have a bleed. And this can really range from super mild with very minimal symptoms where you feel a little dazed, maybe you have a headache for a day or two, to pretty severe symptoms. And I mean, sometimes people can have post-concussive symptoms for years after they have a major concussion, even if they don't have a major bleed. The hallmark of this is post-traumatic amnesia. So there's usually confusion and memory loss of time before and after the injury. So retrograde and anterograde amnesia. So they'll often be confused about the present, and they may forget a period of time before it happens, as well as, the incident itself. But that's not a necessary symptom. So just because somebody is alert and oriented and answering all of your questions appropriately, it does not mean that they don't have a concussion and that they don't need further evaluation. It's also very common for patients to be agitated or frustrated, because these are the patients who are often awake and talking to you, but don't really understand what happened. And so they can make things up. A lot of the time they'll, tell a story. And if you have, this is a time when it's really helpful to be asking the other person who is skiing with them, or friends who have been around them recently, because a lot of the time they will just kind of make up a story because they don't understand why they don't remember. And so they will lie. And you won't necessarily know that unless the friend next to them is like, that's not at all what happened. That didn't happen yesterday. That hasn't happened today. So that additional information from a bystander or from a friend or family member that's with them can be really helpful to determine how confused they are. Okay, so intracranial bleeds, there are really 4 major categories. There's sort of a 5th category, which we'll talk about as well. So this is, I'm just going to kind of teach you a little bit about each kind of bleed, and this is where understanding those layers of the brain is helpful. So the epidural bleed is often happens from lower velocity injuries where there is a blow to the temporal bone, and this results in an arterial bleed. So the threat to the brain in this case is from this expanding mass. I don't know, is my pointer? Yeah. I don't know if you guys can see this, but from this expanding mass, which displaces the brain. It can be laterally, it can be front to back, but most of the time this occurs as laterally, and it causes that midline shift. This is the one that I think it's really important to remember and understand, that when this is happening, there's often a brief loss of consciousness. So the person will have that injury. They'll, their friend or family member may say, when I found her, she was out. But then they will have a lucid interval. So they'll get knocked hard enough that they get knocked out, and then they will wake up and they may seem perfectly fine. But if they had loss of consciousness, I don't care how certain they are that they're fine. These are the guys that you send home and they die in their hotel room. So you need to, if anyone has lost consciousness, or even if you suspect that they may have lost consciousness, be suspecting that there could be an epidural bleed, and it's very, very important to identify this, because again, this is a limited space. And so if it expands to a certain point and we don't get it drained quickly, then it's not a good outcome. They may have a sluggish pupil on one side as the bleed expands, but this is another case where your initial assessment is not always going to show that, because it's an arterial bleed. It usually will expand fairly rapidly, but it's not necessarily going to be there when the first person gets there to evaluate the patient. So this is why with any kind of brain injury or head injury, it's really important to be continuously reevaluating the patient. And so the mortality rate is less than 20% with these if we are able to intervene surgically within an hour. So, that's pretty good when you think about traumatic brain injuries and brain bleeds. So it's really just about making sure that this gets identified and then taken care of. So the next type of bleed is a subdural bleed. And so this is happening under that outer layer. And as you can see from the picture here, it's usually sort of flatter on the edges because it's not being contained by that meningeal layer, and it's compressing directly on the brain. So these are much more likely to kill the patient, mortality rate of 40 to 60%. They're usually a result of venous bleeding and happen because of the direct injury to the brain and tearing of the bridging veins. So the blood collects in that space between the dura mater and the arachnoid membrane. And usually this is what happens in pretty significant trauma. There's generally a pretty rapid onset of the mass effect, which is what's going to cause all those classic symptoms with change in consciousness. And we're going to get into these symptoms in a little bit, but that change in consciousness, the pupillary changes, the rapidly declining mental status is often associated with a subdural bleed. These will occasionally happen though in lesser traumas. And it's important to remember that particularly in older patients who have chronic disease, which can result in weakening of those veins in their brain, and also in individuals who are on blood thinners, where a much more minor injury can cause a more significant bleed. So think about this in your older patients. If you have somebody who had a more minor head injury, but they're older on blood thinners, they could be dealing with a subdural. Okay, so then last two to be thinking about, there's intracerebral hematomas. And so this is actually bleeding that happens within the brain. So if you're thinking about that last picture, this would be if it was in the middle of, in the cerebrum, having an area where there's almost like a bruise in the middle of the brain. And so this can happen from trauma, causes bleeding within the brain. It's usually, again, in more moderate to severe injuries, but these can take a little bit longer to develop. And because they're not causing that massive midline shift, they don't necessarily have symptoms right away. So usually when you have an intracerebral hematoma, you're gonna identify a depressed Glasgow Coma Scale, which we're gonna review in a little bit when we're talking about evaluation. Anytime you see a depressed Glasgow Coma Scale, they need to be evaluated in a hospital. We really need to get more information. So that's really the takeaway there. For the other one then is subarachnoid hemorrhage. This occurs under the arachnoid membrane, and it happens as sort of a layering over the entire surface of the brain. They're usually thin, they usually don't cause mass effect, and they're actually usually from aneurysm rupture, not trauma. So I'm including this here more for completeness sake, but you can have, with these, that often that bleeding will sort of go down lower into the brain, and you'll have those meningeal signs like you might have with meningitis, where you'll have like stiffness and pain with the flexion or extension of the neck. But again, this is something that is less likely to happen as a result of trauma. All right. There we go. So I am including this as this isn't exactly a separate category, but it's not one of the intracerebral hemorrhages. This diffuse axonal injury is a form of TBI that we see in high velocity injuries. So this is actually something that we see fairly often with ski injuries, with snowmobile accidents, and it's devastating. It's really poorly understood. We think that basically what happens is the shearing forces from the speed to stop phenomenon basically rips apart this at a cellular level throughout the brain, and then causes this widespread decrease in the electrical activity of the brain, which basically just means that your brain isn't working anymore. So most of the time, when you find a patient who's had DAI, they're unresponsive at the time of injury. Over 90% of them never recover, and they usually end up in a chronic vegetative state. Okay, so this is the part we're going to talk a little bit. Oh, sorry, did somebody want to say something? No, sorry, I thought I heard something. So we're going to talk a little bit here about skull fractures, but as I said at the beginning, when we're thinking about head trauma, I want you to think mostly about the implications of the brain injury. And basically, if you're seeing what you think is a skull fracture, a facial fracture, a neck fracture, I want you to be thinking about that in the setting of this could also involve the brain, and of course that they need to get definitive care. So things to be watching out for when you're doing your initial survey of the patient. With a skull fracture, you may notice an area of depression of the cranium. If you're seeing that, the likelihood that there is a brain injury underneath is pretty high. So whenever there is a skull fracture, there's that increased risk of having some sort of intracranial hematoma. And often, depending on the size, the fracture itself may require neurosurgical repair in addition to neurosurgical evacuation of the bleed beneath. So if there is a basilar skull fracture, it can cause the cerebrospinal fluid to leak. And sometimes you'll see this leaking from the nostrils or the ears. This you may have heard about. We'll sometimes see that halo sign. If you see the fluid that's coming out of the nostrils or the ears on a piece of gauze, has sort of like a dot in the middle with a ring around it, that can mean that it's cerebrospinal fluid. Again, I mean, that's good for you if you're picking that up on exam, but please don't let trying to examine the fluid that's coming out of their ears or nostrils delay the care. The point with this is, if you have a skull fracture or you're suspecting a skull fracture, you need to get them in to be cared in a hospital setting. So there can also be, with a skull fracture, there can be bruising that occurs around the eyes, which is like the raccoon sign, or also that bruising that you see in the picture down at the bottom behind the ear, which is called battle sign. You're seeing any of these things, this person needs to go to a hospital. And the other thing to be aware of is that because the scalp and the face are so vascular, they're much higher risk of having a significant bleed, potentially even exsanguinating from that injury. And so this is when you're doing your initial survey, and in a next slide or in a couple slides, we'll get into this a little bit. This is actually one of the big things that you need to think about if you're noticing that there is a scalp laceration, a skull fracture, a facial laceration or fracture, is that controlling that bleeding may be important from a perspective of keeping their perfusion up. because if they bleed too much, right, they're going to have hypotensive shock. That's going to decrease the blood flow to the brain, and we're going to have further brain injury because of that lack of blood flow. So again, this is one of those things that I really want this to just signal in your brain, like I'm seeing a skull fracture, I'm seeing a major facial laceration, I'm seeing a major, like this is somebody that needs to be packed and shipped. We really need to get this person to a hospital setting. Okay, so we're going to talk a little bit about the initial assessment and the survey with these patients. So number one, think about bleeding, right? So we got to stop any bleeding. We got to make sure to keep the perfusion up, which means that if they are bleeding out, we got to stop it. Often individuals who have head injury or traumatic brain injury have unfortunately had a collision with a tree or another skier and may be bleeding. So we need to stop that because if they bleed out, then none of the rest of it really matters. So address that first. If you notice that there is a major bleeding injury, get that stopped up, get pressure on it as fast as you can. And then of course we need to be thinking about airway. So there can be loss of consciousness that has resulted in them not breathing. There can be also neck injury or cervical spinal injury, which has resulted in them not breathing. And then there can also be issues with breathing that occur as a result of facial trauma, because if the front of their face is smashed in, then it can be pretty hard to breathe because of that, or actually just the injury to the brain itself, which can shut down the centers in the brain that cause you to breathe. Again, remember, it is really, really, really critical if we can to maintain that oxygen over 90% in these patients, because it is going to give their brain the best chance of having a full recovery. So as soon as you can, get that oxygen on them. If you need to be bagging them, if you need to be we really need to make sure that we are oxygenating. And then the next thing to think about from a circulation perspective is keeping that blood pressure up. So you want to control bleeding quickly. That's the main thing that you can do. I don't remember how much, if you guys get into doing fluids on the scene or not, but this is a situation where you definitely want to try to keep that that systolic blood pressure over 90. And yeah, again, get them control bleeding, get them fluids, get them to a place where they can get fluids as soon as possible. And then once you've managed those initial BACs, you want to start assessing the level of disability. So obviously, if somebody is totally out, it's a pretty quick assessment and you just need to get them moving. But the best way to obtain sort of their baseline status is to do the Glasgow Coma Scale. That is absolutely the standard of care. If you are talking to a paramedic, if you are talking to a physician, if you're talking to helicopter dispatch, that is the sort of best accepted way to evaluate a patient. That's the language that we all speak. But it can be a little bit confusing. And so if you want to do the mini neuro exam, which I know is in your textbook, which is that AVPU, pupils, and best motor response, if that's easier for you to remember, the most important thing is that you're getting an appropriate assessment of how the patient is doing. You're doing something that you feel comfortable with reevaluating where they are to determine if they're rapidly declining. And if that works for you, that's just fine. I don't know at your individual sites what you use as your standard, but know that Glasgow Coma Scale, that's definitely worth understanding and committing to memory. I mean, I still, that's how I read the ER notes about my patients. Like that's the number I see in there, right? That's how the ER physician's evaluating them. That's how the surgeon's evaluating them. That's what we use. And then it's really, really important when you're thinking about disability that you are thinking about ongoing assessment as you transport. Because your plan, it may change, because these patients sometimes will rapidly deteriorate. And so it's just important to be continuing to assess and reassess them to be sure that you've got the right picture of what's going on. The other thing, of course, that I want you to remember about these patients, and this isn't exactly their head trauma itself, and this is a whole separate lecture topic, but they are at increased risk of having that neck or spinal injury when they have had a head injury. So you really want to make sure that you are ensuring proper spinal stabilization, that you're getting that C collar on, doing whatever you need to do to make sure that that is that you get that obtained and you maintain that spinal stabilization, because again, if they're not breathing, then it doesn't, matter if they've got oxygen on their face. Okay, so this is that Glasgow Coma Scale, which is, like I said, definitely worth committing to memory if you feel it's something that you can get a handle on. So it's I, verbal motor, so EVM, and the maximum score is 15, the minimum score is 3. And basically, you assess each of these. So max score of I is 4, max score of verbal is 5, and max score of motor is 6. So you are, some of this you're going to be speaking to the patient. You're going to be assessing, how they're responding to you, how they're obeying commands. If they're localizing, are they localizing with flexion? Are they localizing with abnormal flexion or extension, which we're going to talk about in a minute as well. And really that helps us to assess how extensive the injury is, and really it helps you to determine whether or not they are deteriorating. Maybe. There we go. Okay, so this is the list of symptoms that I want you to be thinking about when you are doing that patient evaluation. It's not to say that any one of these is the definitive or the definition of having had a head injury, but if you are noticing that any one of these things are happening in a patient who has a known or suspected head injury, this should really increase your threshold of concern. So if the pupils are unequal, I mean, maybe they've had some sort of an eye surgery. I will tell you, I've got 1,600 patients. That's the exception. Usually people's pupils are equal and they respond to light pretty equally. If they are not equal and they are not responding to light equally side to side, you should be concerned, because that's usually a sign that that signal from the light is somewhere in the process of it traveling back the eye to the brain, being processed in the brain, and it's sending the signal back out. Some part of that pathway has been interrupted, which is often a sign that there is increased intracranial pressure. Also, worsening headache. So a headache at all is definitely concerning, but somebody knocks their head, they're going to have a headache. If their headache is getting worse, I want you to be concerned because it's not a good sign. Nausea and vomiting, again, this is one of those things that tends to happen when the pressure inside the cranium goes up. ICP up, nausea and vomiting. So if somebody threw up immediately, if somebody has started to develop feeling nauseous, vomiting, they need to be evaluated somewhere else. We need to get a scan of their head. Drowsiness is also concerning, and that goes along with that decreasing level of consciousness and responsiveness. Slurring of speech, again, just as we see with like a stroke, when there is a bleed that is putting pressure on the speech centers of the brain, this is not a good sign. So definitely that should be concerning. Confusion or loss of consciousness we've talked about. Seizures, not a good sign. I'm sure that all of you would recognize that and recognize that that's concerning and be getting that person to care any way you look at it. Fatigue, this is tough, right? Because we have patients who are out there skiing. They may have been skiing for hours, and fatigue is something that they may have been experiencing before they had an accident. But it sort of goes along with the drowsiness. This is one of those things that I want you to at least take it seriously and talk to the patient about it, because if they are experiencing fatigue that's out of proportion to their exertion or their experience from the day, then they need to be concerned about it. Any numbness or tingling anywhere, not a good sign. Not a good sign from a spinal perspective, not a good sign from an intracranial pressure perspective. That's just something to be aware of. Any change in coordination, again, it's like if you see anything that you are thinking of as a stroke symptom, be concerned, because it's probably a sign that there's a bleed. And then orienting, again, this has to do with that Glasgow Coma Scale at Glasgow Coma Scale as well. If they're not sure where they are or who the people are around them, that's a problem. So this is just another one of those things to understand when you're looking at a response to pain. And this is in the person who's not responsive to verbal, who's not oriented, but you are, maybe squeezing their finger between your finger and your pen light. right there at the base of the nail, that usually it's not gonna permanently damage them, but that's something that people will feel. If you see change in posturing where they are pulling inward, so they're not localizing to the pain, they're not trying to smack your hand away or, but they are pulling inward, that's decorticate posturing. And that's actually less severe if they are like pulling their feet, and if they are, if they're pulling their feet in, if they're pulling their arms in, if they're sort of going inward, that is a better sign than if they are going outward, right? So if they are sort of bringing their arms out to their side, like you see in this drawing, that's not a good sign. And if that is the sign that you're using for evaluation, and you see someone move from decorticate posturing to decerebrate posturing, that's actually a really, really bad sign. And so that's just at least something to be aware of when you're doing continual reevaluation of the patient. Something that you definitely want to, let them know when they're going to the hospital setting. Other things to watch for: changes in ventilatory patterns or apnea. Basically, you want to ventilate anyone who has had a brain injury if they are breathing at less than 8 breaths a minute. Someone can still be breathing, but breathing in that Cheyne-Stokes pattern, or having long periods of not breathing between breaths. Anything less than 8, you really need to bag them. And then if they're having an increase in blood pressure, or what we call an increase in like the pulse pressure, so that's that their systolic is going up and their diastolic is going down, also not good. And again, we need to think about, well, we want to make sure that they're maintaining adequate blood pressure. If their blood pressure is going up too much, right, that's going to increase blood flow in the brain, which is then going to increase the swelling, which is then going to put more in a small space, which results in further damage. And then if you're seeing decrease in heart rate, that's another one of those feedback responses from the brain. Not a good sign. That's something that if their heart rate is going down, then you need to transport as soon as possible. So one of the takeaways that I really want you to have when you are evaluating these patients, because the truth is that the person who has a really, really bad head trauma, that's actually an easier one to make a decision on, right? You see that somebody is obtunded, they're confused, or they're completely out. This is not a hard decision to make, and they're not capable of making any decisions for themselves. So they're going to the hospital. The patients with brain injury that are more difficult are the ones who maybe have that epidural hematoma, and they had loss of consciousness, but now they feel perfectly fine. So the thing that I want you to remember as the professional is, no matter how much they're trying to convince you, it's probably not a hangover. It's probably not the altitude. It's not the flu. It's not whatever else they're telling you. If they are having any of those signs or symptoms, and you suspect or know that they have had a head trauma, you need to be using your best skills of negotiation and informing them about what you're seeing and why it's concerning you as the professional, to convince them that they really need to be transported to be evaluated. Because those patients, if you did everything you could for the person who was dead on arrival, you did everything you could. The ones that will really haunt you are the patients that you could have saved. And, and that's the part that I want you to remember, is that you play a really, really big role in convincing someone that you're seeing things that make them worried that they need to be further evaluated. So please do that. Use your best negotiating skills and help to get them to the care that is most appropriate for them. So my management summary is, of course, number one, as always, address the life-threatening problems while you're protecting the spine, and transport and ship. If somebody is looking like they need to be transported and shipped, please do that, because with head injury, that's honestly, there's really no good way to assess this in the field if you're suspecting that there's a significant TBI. So, I mean, it feels maybe a little bit like oversimplifying it, and I recognize that there are going to be a lot of people that just want to get back out there, want to go back to the hotel. But if there is anything that you are concerned about, the best thing to do is to get them a CT scan of their head to make sure that everything's okay on the inside. Remember that you want to do that supplemental oxygen. This is really one of those cases where oxygen is super important, and you want to ventilate if they're breathing at less than 8 breaths per minute. You want to control bleeding and maintain blood flow. So if somebody has an injury to their brain, we want to keep the perfusion up and we want to keep the oxygen up. So doing all the things you can in the field to do that is very important. And then you want to monitor continually. The other thing that is sort of an interesting change from how we think about transporting trauma patients when you're getting them down off the mountain. This is a case where there's a head injury. This is a case where we actually would recommend transporting with the head uphill. And the reason for that is, while we want to make sure, you know, with shock, right, you want to make sure that they have enough perfusion to the brain. So if somebody's in shock, it's like, we'll transport with head downhill because we want to make sure they're getting enough blood flow to the brain. In the case of a head trauma, you actually want the head to be uphill because that increased pressure, right, that we're trying to avoid by giving oxygen, that we're trying to, you know, avoid by keeping the perfusion at the right levels, that will get worse if their head is downhill. So, so this is something that's a little bit different when you have head injury versus in other cases where you're concerned about shock. And then another thing to just remember is that if removal of the helmet, this is a little bit of a sticky situation. So generally speaking, removing the helmet is something that you want to do only if for some reason you cannot get a good airway. Absolutely. If you can't bag them or you can't give them oxygen because of the helmet, then you need to stabilize that C-spine and get it off. But it's also important that you are able to stabilize the C-spine during removal, which I know you guys practice this, and I think in your workshop we'll be practicing it as well. Also, you know, a reason to remove the helmet is if the helmet is preventing you from immobilizing the spine, or in the case of cardiac arrest. So, you know, any of those situations, you absolutely want to get the helmet off so that you can give the patient the care that they need. Otherwise, you don't necessarily need to prioritize removing the helmet because, yeah, it's actually, I mean, the injury itself is actually contained by the helmet, and the most important thing is getting them out safely as soon as possible. And then just again, stressing that refusal of treatment and transport is really, really common in people who have had head injury, especially those mild to moderate head injuries. So just use your best negotiating skills. Remember that you're a professional. And if you feel that somebody lacks medical capacity, meaning that you feel that they are not making decisions, that they are making decisions that are not appropriate because of the fact that they have a head injury, involve your director, get in touch with the lead of your team, sometimes even involve law enforcement, because it's really, really important to make sure that that they get the care that they need. It's not your job to be their friend, it's your job to save their life. And so, you know, really certainly try best with your kindness and negotiating skills. If somebody is responding well to that, that's always the best way to go. But if you really think that they are injured to the point that they don't have medical capacity and that they don't have decision-making skills, you know, bark it up the line if you think they need additional care. Okay. Why won't this go forward sometimes? Let me see. There we go. Okay, and this last slide is not exactly a slide that is part of the lecture itself, but I just want to mention to all of you that caring for people who have had a severe brain injury can be traumatic for the caregiver as well. And for those of you that have been on patrol a while, you've probably seen some of these incidents and they may continue to haunt you. So the trauma that you experience from taking care of these people, it can impact your mental health, and which therefore impacts your safety and the safety of everyone you take care of. So I just encourage you, I know that you guys have really good resources within the patrol. Please don't hesitate if you have taken care of someone and you're really struggling with it, to reach out to your directors, to reach out to community members like me. If you're struggling with processing trauma, there are a lot of people out there who can help. And it's not anything to be ashamed of or embarrassed about. I will share a personal experience that I had. This was not a head trauma, but I was the first person at the scene when a woman was run over and dragged by a dump truck. And it's still, honestly, to this day, you know, I've processed it, I've dealt with it, but it's something I still think about. And when you see some of these really gruesome injuries, as can be the case with traumatic brain injuries, it can stick with you. So don't be afraid to reach out and get the help that you need. And thank you to all of you for everything that you do to keep us safe on the mountain. Myself and my family, we all, everybody here in the community really appreciates everything that you guys do. All right.
I have to say, I'm going to get the questions first in a minute. And we do have two really good questions to answer, and then several others that I want to address. But the first thing I need to tell you, and I bet most of the patrollers are feeling the same way, you know, you were the first one of our preseason lecture series that hasn't been a patroller, but you would not know it from this lecture. This lecture, you really had it right where we need to be to talk about things we need, understanding what it's like to be at the scene, understanding what they need to know about separating between the ones who are going to be real clear, the ones who are, oh my gosh, put the helicopter on standby or call for the ambulance and then the ones who are going to be the ones that are difficult. So thank you. So let's go to the questions here and then we'll talk some more. So the first question, and this gets right into it. Kate was kind enough to ask you, and I'll respond to this too. How is catastrophic injury defined?
Yeah, so I was looking at this actually earlier today, and this is from those reported resort inbound, you know, patrol cared for. So catastrophic is not just individuals who died, but then also includes individuals who have lifelong disability as a result of the accident.
You know, I wish I could add to that, but I can't. It's, you know, if you talk to many people who don't research that, you know, everyone will say something's different with catastrophic. I mean, for some people it's catastrophic if they forgot a glove when they get to the ski resort. But yes, that's a good answer. And hopefully—
I have a son who's like that.
hopefully, Kate, that answers that. The next one from Greg: how long is the lucid period of an epidural bleed? As in, when do the vitals crash?
Great question. And the answer is there's no answer to that. It can be short, it can be long. It's not unusual for it to be even up to 24 hours. Though typically it's within a few hours. Yeah, but there's no right answer. And it really just, that's one where it depends on how fast it's bleeding. So I wish there was a good answer to you. The biggest thing to remember with this is if there has been any loss of consciousness, we really need to be thinking about getting a CT scan, which you just aren't going to do at the Hill. So, yeah.
So again, you know, the only thing I'd add to that is that, you know, this is part of the knowledge that you have to be able to convince those people who say, I'm okay, even though either—
Oh, we lost you, Winnie. It looks like you got muted.
I'm back. Can you hear me now?
Yep, can hear you.
Yeah, sorry about that. I said that's also a good answer, and it goes against what we're trying to do as far as doing less CT scans on kids. But when it's someone who has lost consciousness or someone who thinks they're okay, you have to say how hard they hit, look at their helmet, everything, and err on the side of being safe. And this is the time. She kept saying, you know, call your director. I'm happy for you to call me to talk to their friend, their mother, their sister, whoever it takes to get them to do what's right. Because, you know, we're all aware of that terrible case of a celebrity who was urged to go get a CT scan, went back to her condo and died. And we don't want that to happen to her, and we don't want it to happen to anyone else. So that's good.
Yeah, and I didn't really get into this, but it is important for you to be considering the mechanism of injury, right?
Yes.
So what
Yes.
Winnie said about looking at their helmet, looking at the surroundings, this is where you being the one who's on the mountain and seeing what is around that patient, you know, if they're not getting themselves to you, if you're going to them, you know, you want to take in all of that information at the scene and really incorporate that into your description and your understanding of that mechanism of injury, because that's sometimes your best way to determine whether or not this is something more serious.
And I'll use that as a lead into one of the things I was going to say. Like I always say, what you do is so vitally important because you are the first point of contact. And if, say, they're in that lucid period and you found out that they were on a heart medicine that prevented their vital signs from changing, and we can get, lulled into thinking, well, they're really not going into, having a really bad injury. All the information you get in the beginning is so vitally important, first because it changes, but also so we can see how it changes when we see it. So again, that initial history that you get, the initial findings you have, if their pupils are normal when you saw them and now they're not responding to light, that's a huge deal for us. So what you do is so vitally important. Okay, next one is, when working with a looping patient, what tips do you have for determining to keep getting the patient history versus immediate transport?
That is a great question. So again, I think some of this is really, some of this is your gestalt at the scene, right? Obviously, if you are noticing that somebody, if you're talking to them and you're getting history and you're noticing that somebody's declining, you need to transport them immediately. But sometimes that time that you're spending sitting there and talking to them, that could make the difference between them deciding to go or, sort of refusing transport, which they can do. I don't know, Winnie, do you have any great suggestions? I feel like sometimes this is a little hard to figure out. When in doubt, transport. If there's a question in your mind about whether or not somebody needs to be taken off the mountain and get into and needs to be in more definitive care, you are always better to err on the side of caution.
Yeah, what I would say is, if they're perseverating, try not to laugh, because it's sometimes funny because you can't believe they keep saying, "Where am I?" or "Who are you?" or they may be talking to their husband. I think if they're perseverating, that's when you call to start the transport. And if you get lucky and they clear quickly and then they can answer questions, that's fine. But it's already obvious. What we are always trying to do is to anticipate. And it's real easy. When you get on the scene, the first thing you should do is see if you need, oh my gosh, ABCs and Ds and bleeding. You need all those things. You're going to act while things are happening. But once you've established it's not that, you don't want it to get to that. So if you have the suspicion, get help, because you're not going to be treating them on the hill. It's always easier to say, gee, by the time they get down and someone looks at them and decides that they don't need a CT scan or something, that's okay. We want to get them out of there and not have an event happen on the hill. We want to be as quick as we can. Okay.
Yeah, and it can be tough it can be tough to redirect a patient who's, this happens in patients even who haven't had a brain injury, right? Sometimes it can be really difficult to redirect somebody. Don't be afraid, to step in and interrupt and say, hey, I understand that you really want to get this information to me, but I'm concerned that we need to get you off the mountain first. We'll have lots of time to talk about this. You may or may not, depending on how the transport goes, but we'll have a lot of time to talk about this when we get to the bottom. But I want to make sure we're in the best place to take good care of you, and that's not here on this slope sitting in the snow.
And that, well said, very, very well said. And use all your interpersonal skills, and if you need our help, give us a call, and we will add a couple letters to the end of our name to help make it. Let's see. I think
all the questions.
That may be all. Does anyone else have any other questions? A couple things I wanted to tell you. The first is, again, reiterate, every time she said, call your directors, you know how to get a hold of me or my partner, Chuck, or us. We will back you up. The next thing that's very interesting, I try and learn everything every day or once a day, but I also try and teach one thing. So Mary, I want to tell you something that I learned from another training I was doing. And they told me that in the East, where the slopes aren't as steep, that even though the recommendations about the head up or head down are there, since it's not steep, they don't do that. They just ignore that. out west here, we don't have that luxury. So we have to think.
Yeah, but they might also only have 700 of vertical to get down. You might have 3,000. It's a little different.
Exactly. Exactly. One of the questions that wasn't asked, that is a tough one, is, should I use a helicopter to get these patients off when you know you're going up and so forth? Well, it's a judgment call that where you're located versus are you going to be intubating the patient, therefore you can control the oxygen? Those are tough questions that we should help you with. You're certainly the experts on where you are and how hard it is and how long it takes to get off. But we can certainly help you determine, gee, maybe if you can get the ambulance quicker, then we're not going up and not getting the oxygen in the brain, which is so important for lessening the pressure. Let's see, I talked about that. Oh, one other thing I'll tell you, that as Mary said, we do use the Glasgow Coma Score. And I know that you have those maybe even in your packs, but it's good to have. They're difficult, but if you can make your best guess and remember one thing, if it is 8, they need to be intubated. If it's 8, intubate is what we go as physicians from our side. So that's where it's severe enough that this is a life or death thing, because they are in bad shape, and we want to control that airway and get the oxygen to them to make it not worse till we can evacuate their bleed. That's all the things I can think of that I have on my list. Does anyone else have any other questions besides the guy in the picture? What was his question? I don't know. Well, again, we are 2 minutes over, but this was great. And Mary, I can't thank you enough. Like I said, no one would know that you're not, besides being an amazing physician, but you're not also a ski patroller. And you may get some patrol directors calling you to ask you if you want to patrol part-time, because you certainly know how to approach the mountain.
I'm not sure that I could hang with you guys, but I very much appreciate that you're out there to help. And I hope that what I'm bringing from the wilderness EMT world is helpful to all of you. So thanks for having me again. I really love doing these lectures and look forward to seeing some of you at the in-person review next week.
Okay, well, we'll let everybody leave. And Sue, I know you're still there. If you could hang for a minute, Mary, hang for a minute.
Yeah.
We will talk just a second.
Okay.